Dr. Devrat Singh Parmar, Assistant Professor in Cardiology. Today I am going to discuss about carotid artery stenting, anatomy, procedure and the complications. So we'll be discussing under the following subheadings. First is anatomy with angiographic images, carotid artery disease and stenting, its indication, procedures, post-procedure care and follow-up, and the complications. And we'll be also discussing about the studies, latest studies, trials, available literatures. So first is anatomy. So as we all know, the aortic arch usually it's divided into three major components. First comes your right brachiocephalic trunk. From the right brachiocephalic trunk, it differentiates into right subclavian and right common carotid. Then left common carotid and left subclavian artery. Okay. So now your common carotid artery divides into ICA and external carotid artery at the superior border of laryngeal cartilage. Okay. Now external carotid artery extracranially gives multiple branches such as facial, lingual, glossopharyngeal arteries, while internal carotid artery do not give any branch in the extracranial component. It goes into the intracranial and then divides into middle cerebral artery, anterior cerebral artery and the posterior communicating artery that helps to form the circle of Willis. Okay. So as we all know, there are various components of the internal carotid arteries. It consists of first is cervical component, petrous, lacerum, intracranial and then the communicating branches. Okay. So as we all know, there are multiple branches of the internal carotid artery and the major components of is all same, that internal middle cerebral artery, anterior cerebral artery, posterior communicating artery, meningophyseal artery, anterior choroidal arteries. Okay. So this is a whole circle of Willis that both internal carotid artery forms the middle cerebral artery, gives the anterior branch to the anterior cerebral artery, and then behind it gives the posterior communicating artery. And there are also certain direct branches that arises from that. That is like this anterior choroidal artery and the ophthalmic arteries. Okay. So now for carotid artery disease, the gold standard is your angiography. Okay. So in angiography, the best projection to identify the carotid artery disease is your AP view. You can also get a lateral view to differentiate between the ICA and the external carotid arteries. Okay. And RO projection, it helps to differentiate the branches of the brachiocephalic trunk is the best. Now in the straight PA cranial view, that is like Townes view, it helps to identify the intracranial component of the internal carotid artery and to identify the blood circulations. So always do remember, whenever you are getting an angiography, always it should consist of the three phases: arterial, capillary and the venous phase. So you should always continue, the cine images should always continue till the venous phase of the circulations. Okay. So this is, as you can see here, this is the intracranial selective angiography projection. Okay. So this is like the baseline patient positioning should be, it's like the patient should be lie down in the supine position, head should be supported with the radiolucent head holder or the curved sponge and strap across the patient's head so that you can see in a better view. Okay. Now there are certain different projections to see the internal carotid arteries. First is your PA projection. As you can see here, there are three images we can see here. This is the frontal internal carotid arteries. First is your arterial phase, then capillary phase and the venous phase. Now this is the lateral projection, how the ICL looks like in the lateral projection. So this is the right lateral. Here there will be minimal dose to the operator, and here also we can see all the three phases. And this is your ICL looking in the transorbital oblique projections. Okay. So basically these are different projection how the ICL looks in the different projection, and this is your reverse transorbital oblique projections where the petrous ridge is positioned on the infraorbital margin. This is a contralateral obliquity at 30 degree. Okay. And central to induce the lateral edges. Okay. So now coming to the carotid artery disease. Now when you consider the carotid artery as significant when the lesion is more than 50%, okay, and the extracranial component of the ICA. The symptomatic is like if the patient has a history of TIA or stroke within the last 6 months, and asymptomatic will have no prior symptoms or symptoms more than 6 months of age. Okay. Now what are the indications when you have to intervene in a patient of carotid artery disease? If the patient is symptomatic, stenosis 50 to 99%, okay, or in a non-invasive imaging technique such as Doppler, you identify the lesion more than 70% with the peri-procedural risk of death less than 6%. While asymptomatic, the lesion should be more than 70 till 99% with the peri-procedural risk of stroke less than 3%. So, now what are the imaging technique? How will approach a patient for the imaging of the carotid artery disease? The first investigation screening test to identify is your Doppler L. Okay. Then once you commit that okay, the lesion is significant, now you want to do intervention. For that you need to get CT angiography or MR angiography, that is mandatory before any intervention of the carotid artery disease. Okay. Either you are doing either carotid artery stenting or carotid endarterectomy. Okay. Now revascularization in a patient of asymptomatic significant carotid artery disease. So here again, either it's an average surgical risk or high surgical risk. In asymptomatic, if the patient is average surgical risk and if the patient stenosis is 60 to 99%, okay, with the increased risk of ipsilateral stroke, then it's a carotid endarterectomy is a class 2A indication. Well, if the lesion is in a high surgical risk, if the patient stenosis is 60 to 99%, and with the increased risk of stroke, again it is a class 2A indication. Okay, and similar carotid artery in an asymptomatic patient 60 to 99%, carotid artery stenting is class 2B indication. Now coming to symptomatic carotid artery disease, if the patient is symptomatic, the patient had a history of stroke or TIA within last 6 months. Now here, if the stenosis is 70 to 99%, it's a class 1 indication endarterectomy. If the lesion is 50 to 70%, endarterectomy is class 2A indication, and stenting is class 2. Again, the stenting is class 2A indication. Again, you have need to remember, if the patient had a symptoms, we should undergo revascularization by anything. Endarterectomy or stenosis within 15 days, that is class 1 recommendation. Okay. So how will approach to the patient of carotid artery disease? If the patient had a recent symptomatic TIA or stroke within last 6 months, yes, then the first imaging technique we all know, that is Doppler ultrasound. Now in Doppler ultrasound you identify the lesion severity. Okay, so you identify that the patient is symptomatic and if the stenosis is 50 to 69%, endarterectomy plus best medical therapy is class 2B indication, while stenting is again class 2B indication. And if the stenosis is significant, 70 to 99%, endarterectomy is class 1 indication, while stenting with best medical therapy is again class 2B indication. Now in asymptomatic patient, in asymptomatic, if the stenosis is 60 to 99%, life expectancy is significant, more than 5 years, then endarterectomy plus best medical therapy is class 2B and stenting is again 2B indication. And the last but not the least, you should always remember, in a carotid artery disease, if the occlusion is 100%, it is always the aggressive medical management. Okay, you should never intervene the patient. That is, it's like class 3 indication. Okay, so initially, whenever you are approaching the patient of carotid artery stenting, first you have to assess peri-procedural assessment, clinical and anatomic. First is the age. If the age is more than 80 years, okay, so it has got the worst outcome. Then either patient already had certain deficits like cognitive impairment or dementia, it has also got the worst prognosis. Then you have to assess the anatomical images of the arch of aorta, that you can identify by CT angiography or MR angiography, and conventional cath angio is the gold standard for the diagnosis of carotid artery stenting. Okay. Now there are certain high risk when you are taking a patient of carotid artery stenting. There are certain high risk features for it. It is both clinically and anatomical assessment. In the clinically, if the patient is elderly, bleeding disorder, severe aortic stenosis, severe renal disease, decreased cerebral disorder, dementia. In the anatomy, if the patient had a high aortic arch, type 2, type 3 aortic arch, stenosis at the origin, more than 2 acute angle, circumferential calcification, tandem lesion, lack of femoral access, or unable to use embolic protection device. So now we will identify the types of aortic arch. So basically there are 3 major types of aortic arch. Now it is based on the distance from the brachiocephalic trunk to the high origin of the aortic arch. So if the distance is if the distance is similar to the diameter of the common carotid artery, that is type 1. In type 2, the distance from the origin of brachiocephalic trunk to the high aortic arch, if the distance is 1 to 2 times, that is type 2. And type 3, if the distance is more than 2 to 3 times of the common carotid artery, that is type 3 aortic arch. So type 1 has got a better prognosis. Type 2 and type 3, it is difficult to intervene. It is difficult to basically cannulate the common carotid artery. Okay. Now, again, how you here we differentiate the aortic arch based on the distribution. So type 1, so first image, as you can see here, it is the commonest aortic arch what we see in day-to-day normal practice. That in aortic arch, it has first is your right brachiocephalic trunk, then separate left common carotid and separate subclavian artery. Type 2, it is also known as bovine arch. Okay, now it is the next more common cause. As we can see here, the left common carotid artery and the brachiocephalic trunk both of them have got the similar origin, while left subclavian is different. Now in the type 3, it is again rare. Okay, where we can see here the left common carotid arises from the right brachiocephalic trunk. Okay, and the type 4, it is a rarest to the rare, where there is a single brachiocephalic trunk where all the 4 major components of artery arises from that same aortic arch. Okay. Now there are also certain high risk features for the carotid endarterectomy. Like clinically, if the patient is in failure, multivessel disease, unstable angina, recent MI less than 30 days, if the patient is severe LV dysfunction, LV of less than 30%, severe pulmonary disease or severe renal disease. There are certain anatomical features also where it is difficult to intervene for the carotid, such as if it is very high above origin, that is at or above C2 level, below the clavicle. If the patient had already received the radiation therapy, spine immobility, contralateral also if the patient is having carotid artery occlusion, contralateral laryngeal palsy, tracheostomy, or if the patient has prior ipsilateral endarterectomy. Okay, so whenever you are approaching a carotid artery disease, the first thing you try to get is an angiography, because it's a gold standard. So in angiography, the commonest site what we use for the carotid artery disease is your femoral site. Okay, you use the 6 French JR catheter and then go and take the carotid imaging. Okay, so first thing, you take a femoral access, you give the heparin, that is 25 units per kg. Then you identify the anatomy of the carotid. That is like type 1, you can easily cannulate with JR, and if it is type 2 or type 3, you have to cannulate with either Siemens catheter or Whitek catheter. Okay, so these are the different types of catheters, such as Bernstein, Whitek, JR, Siemens and MPLATS catheter that helps to cannulate your carotid arteries. Okay, now intervention techniques. So now when you identify the patient is having significant lesion and you're planning for revascularization, so you should always remember certain things. The patient should be loaded with aspirin plus minus clopidogrel. Loading dose should always be received. Before procedure, patient should receive the unfractionated heparin. Okay, that is 25 units per kg, and the ACD during the procedure should stay between 275 to 300 seconds. Okay, and you try never to sedate the patient, because you have to analyze the neurological status during the procedure. Okay, so first thing is like for the diagnostic purpose, you take a 6 French catheter. Now you identify the lesion is significant, then you change from the 6 French to your 8 French catheter. Okay, so first thing, you take a GR catheter, you take the straight tip MPLATS wire, straight tip Teramo wire, you go till the common carotid artery, then you change that JR to the guiding JR 8 French catheter with the MPLATS straight tip wire, and you take with a it's like guiding, it's like catheter. Then once you have reached the common carotid artery, you should always remember the most important thing, it's like after changeover, that your MPLATS stiff wire should never cross the lesion, because if it crosses the lesion, it will directly embolize and it will cause a stroke. Okay, so first thing, once you have reached the common carotid artery, your guiding catheter has reached the common carotid, then the first thing what you do is like you put the embolic protection device. Okay, so in embolic, you take the wire, you cross the lesion, and then you reach till the distal component of the ICA, like extracranial component, and it should be like try to keep the wire to the most straight part of your ICA. There are different filtered available. The commonly what we use here is like your embo shield. Apart from this, you can use Acunate, embo shield, spider, angioguard, filter wire, and the fiber net devices. Okay. So once you have put the your embolic protection device in the distal part of the IC, then so these are actually basically these embolic protection devices. They are differentially based on your pore size. There are different pore size for each and every embolic protection device. Okay, so here you can see here the different types of embolic protection device, such as first is your angioguard, then is your Acunate, then is your spider, then your is your filter wire, and then filter wire EZ. Okay, then once you have put the embolic protection device, then you can directly pre-dilate the lesion. Okay, you can pre-dilate the lesion with your Maverick. It's like there is Maverick 3 to 4 mm balloon, so that the lesion gets properly opened up. Okay. Now, once you pre-dilated the lesion, you know that the lesion is properly prepared. Then you go for your stenting. Okay. So earlier we used to use this inflexible stainless steel balloon, but because of the excessive neck movement and that all, the fracture was very high, so the stent used to get crushed. So now what we use is your self-expanding stent, so which confirms the tortuous anatomy and change the vessel size. Okay, and there is decrease it's like stent crushing. Okay, so here the major component consists of this nitinol, large elastic range, and can withstand the deformation. Again, it is of two types. One is open cell and closed cell design. It depends on what type of lesion and what type of tortuosity and calcification is there. Based on this, we can use. There are different sizes of stents that are available in the market. The commonly used stents that are 5 to 10 mm and the length is around 20 to 40 mm length. Okay. Now, the commonly used stents are tapered stent. Okay. The tapered stent, because there will be entirely different. It's like diameter of IC means common carotid artery. Okay, so taper stent confirm the size of IC and MCA both and facilitates to keep the stent in a bifurcation. Okay, and it also consists in the length of 20 to 40 mm. Okay, so basically, if the lesion is very tortuous, open cell design is preferable, while if it is a calcified, it's difficult to open. Here we use the closed cell design, so that okay, it helps to properly oppose and helps the outward expansive forces. Okay. So now angioplasty and stenting, the post balloon dilatation. Basically, once you put a stent, then it's like post dilatation of the self-expanding stent. You can dilate with 4.5 to 5.5 diameter NC balloon. Okay. But the greatest risk in the post balloon dilatation is your distal embolization, the slow flow, no flow. So you should always remember that when you put a stent and at that time you identify the patient as slow flow, try that. If we got the optimized result, we can even prevent the post stent balloon dilatation. Okay, because the major slow flow, no flow usually arises during the post stent balloon dilatation. Okay, now residual stenosis of less than 20% is usually acceptable. Okay. So as we told, the major complication is your slow flow. Slow flow, it usually arises due to the excessive embolization of the plaque element that occludes the filter pore comprising antegrade flow. So there will be complete cessation of the antegrade flow. It usually arises in 8 to 10% of the cases. Commonly arise after the post balloon dilatations. Predictors are if the patient is symptomatic, increased stent diameter, and the advanced age. Now, once it has happened, the patient develops slow flow, no flow, you try to aspirate 40 to 60 ml of the column of the blood proximal to filter using an export catheter recommended to prevent the distal embolization of debris before retrieval. Okay, so always remember that during the procedure, during the stenting only, if you identify there is very high prediction the patient will get slow flow, try that. Okay, and if the stent is well opposed, try not to do the post balloon dilatation. Okay. So this is a schematic diagram that has shown that what are the proposed mechanism of the slow flow, no flow. The first thing slow flow arises when you cross the lesion with a wire, then when you pre-dilated, then when you put a stent, then during even the export catheter when you are pulling back, at that time also certain debris can go to the distal component and it can cause slow flow. Okay, so this is a diagram that has shown the first image. When you can see, this is an angiographic image where you identify there is a significant lesion in the ICA component. Then you have pre-dilator. Then first thing you have done is like you put a filter. Then you have done a balloon dilation and then stenting. Okay, so once you have done a stenting, remove the embolic protection device and then get the final image of the carotid arteries. Okay, now in the post procedure, what are the things you have to remember? Keep the patient in the ICU. Okay, watch for neurological deficit at least 48 to 72 hours. Keep the pressures under control. The pressure should be between 120 to 160. Okay, and lifelong aspirin should be there. Single antibiotic he'll continue, and if the patient was symptomatic, you can give it for the DAPT at least for the 1 month. Okay, then this is a manage how you will manage a patient who underwent revascularization. Okay, so if the patient was asymptomatic, single antiplatelet for the whole life. Patient was symptomatic, you underwent stenting, 1 month DAPT followed by single antiplatelet whole life. Surgery, single antiplatelet for the whole life. There is okay. So now, what are the possible complications in a carotid artery stenting? Now we'll start from the basic. First is your access site. In the access site, because as you have to take the 8 French catheter, okay, the commonest is your local hematoma, pseudoaneurysm, AV fistula, and RPH. Okay. Now, once after access site, the other next common component is like complication that arises on the catheter. There is your embolization, because usually what happens, these are the people that have high risk of even calcification in the atherosclerotic plaque in the major aorta. So there is very high risk of embolization, the dissection. Okay, then lesion. There are all the complication for the intervention is like the aortic undergo spasm, dissection, embolization, thrombosis, stent, underexpanded, filter retrieval failure, or if there is dislodgement of the material during the filter retrieval. Now the commonest complication during this carotid artery stenting is stroke. Okay, the most important complication is stroke, that constitutes around 2.3 to 6.9%. Okay, and 80% are ipsilateral, and out of this 33% are the major stroke. Okay, and it can occur any time of the procedure, extremely low risk beyond 30 days. Okay, and most of the stroke that arise during the intervention, out of this more than 80% are ischemic stroke. Okay, and hemorrhagic stroke accounts for 15 to 20%. Okay, now deficits can arise. So now the next common cause during the carotid artery intervention is your hemodynamic compromise. Okay, so basically what happens is like whenever you are putting a stent or when you are doing the post balloon dilation, the baroreceptors get activated, and this efferent nerve fibers are the glossopharyngeal nerve that stimulates the vasomotor centers. Okay, and that usually has 3 major components. It's like this medullary vasomotor center are stimulated, that again stimulates the vagus nerve, and it causes vasodilation, decrease the heart rate, and it inhibits the sympathetic nerve. So these are the 3 things what happens is like peripheral vasodilation, bradycardia, and the decreased cardiac contractility. So whenever in the post balloon dilatation, if the patient can develop suddenly hypotension, bradycardia, or the patient can have decrease in the cardiac contractility. So immediately whenever you are doing a post balloon dilatation, always keep the atropine ready. One is your atropine, either if the patient has a significant vasodepression like hypotension, you can even use this epinephrine or adrenaline. Okay, so again, so the treatment is same like fluid management, atropine, epinephrine, and the dopamine. Okay, now the next common complication of the carotid artery stenting is a hyperperfusion. Usually what happens in a significant lesion, a very significant lesion lasting for a longer time, your cerebral autoregulatory system undergo damage, because usually cerebral autoregulatory system is usually maintained if the mean arterial pressure is maintained till 40 to 60. If there is a complete occlusion or near total occlusion, the cerebral autoregulation system undergo dysfunction, and then when we suddenly open up the artery, there will be significant increase in the cerebral blood flow, and that causes interstitial edema, and there is very high risk of hemorrhagic stroke in these patients. So, okay. So basically its incidence is 1.3%. Most cases usually arises within 24 hours. Patient will have throbbing headache, patient will have blurred vision, all the features of raised intracranial pressures. Okay. Once the patient has developed, initially get a CT brain done. You identify the patient got a hemorrhagic stroke, start with antihypertensives. Okay, try to control the pressures. Okay. ISR is usually a late complication, little bit rare. Incidence is only 3 to 4% at 18 months follow-up. So we can get a sonography at regular interval to identify the ISR. ISR is also a low rate of clinical events, so it is little bit less as compared to the other thing. Adverse cardiac events, yeah, high risk stenting registry and trials, 30-day incidence of MI is 0 to 2.5%. In a high risk carotid artery stenting compared with endarterectomy, stenting has got lesser incidence of MI as compared to the endarterectomy. So now we'll come to the literature. What the literature tells about your carotid artery stenting. Carotid artery stenting clinical data review of literature. There are large trials, but the largest of that landmark trial for the carotid artery stenting is your CREST trial. Basically in a CREST trial it has shown that there was no difference between endarterectomy and stenosis in a symptomatic patient. At the end of 30 days, rate of stroke, death and MI, it was not differentiated between stenting and endarterectomy. Okay. So other study was ICSS study. Basically ICSS was a negative trial where the embolic protection device was optional, and actually even there was inexperienced operator were permitted. So it was a negative trial for carotid artery stenting. Okay. So what currently recommendation for the carotid artery stenting? It shows that okay, the carotid artery stenting initially it was the alternative to endarterectomy, but now in symptomatic patient, carotid artery stenting is indicated for revascularization in selected patients. Now the other next landmark trial is Sapphire trial. Sapphire is the only randomized trial that has compared the higher surgical risk of patient of a carotid endarterectomy, and it was a positive trial, and it showed that okay, it has enrolled the symptomatic and an asymptomatic patient both, and in a high surgical group of the endarterectomy. It has showed that the primary endpoint was significantly low in a carotid artery stenting as compared to the endarterectomy. So from here the recommendation was symptomatic high surgical risk patient who qualify for the revascularization are reasonable candidate for stenting. So there were large number of trials that has compared carotid artery stenting versus endarterectomy in asymptomatic patients. There was like Sapphire, CREST, ACT1, SPACE 2 and ACST. Okay. So there was also study, OX-VASC study. There was Oxford vascular study that has showed if once the patient had developed a stroke, there is very high chance of the recurrent stroke. Okay, with the time. So if so it has shown that there is a linear associated with the degree of stenosis with the higher stroke rate in a patient with 80 to 90%. So it says that with the increase in the stenosis, the risk of recurrent stroke is significantly higher. Okay. Now, what are the optimal medical therapies? You should always focus on preventing stroke. Treat hypertension because the hypertension is a major component that increases the incidence of stroke. Reduce sodium and DASH diet. Statins to lower the LDL cholesterol, antiplatelet therapy with aspirin, and there is no evidence for DAPT in the primary stroke prevention. Okay. So for prior stroke or TIA, treatment is more stringent. Statins with ezetimibe, try to keep the LDL cholesterol less than 70. Should have good glycemic control, less than 7. Anticoagulants in all F patients, non-cardioembolic stroke, aspirin, clopidogrel, aspirin plus dipyridamole. And for patients with minor stroke, DAPT is recommended. At least for it should be started within 12 to 24 hours and should continue till 3 weeks or 3 months, followed by single antiplatelets. Okay. So how you will treat in a carotid artery disease? Now, once if the patient is asymptomatic. If the patient is asymptomatic, you have to identify either the patient is a candidate for high surgical risk or non-high risk features. Okay. If the patient is high surgical risk, you can keep the patient for the stenting plus OMT or OMT alone. If the patient is non-high surgical risk, you can give an option for endarterectomy or stenting. both you can give. While in symptomatic, again, if the patient is symptomatic, the patient had a history of stroke, TIA, high surgical risk, you can give the patient for stenting plus OMT, non-high surgical risk, aneuploidy. Okay. Now, this is a major component. How you will screen for carotid disease in a patient undergoing CABG. Now, in a patient undergoing CABG, Doppler ultrasound is the initial screening test, but it should be done in all the patient if the patient had a history of TIA or stroke within last 6 months, like symptomatic patient, that is class 1 recommendation. Now, if the patient is elderly, multivessel disease, there is a BRUI, again it is a class 2B indication, but routinely doing Doppler is class 3, it's of no benefit. Okay. Now, how will you manage a patient undergoing CABG? Now, if the patient is undergoing CABG, you identify the patient is having stenosis. Okay. Now, if the patient is asymptomatic or symptomatic. Okay. Now, in a patient who had a symptomatic, then carotid revascularization should be performed in a patient with 50 to 99% stenosis revascularization. Here, the aneuploidy is class 2A indication. Okay. If the patient is symptomatic and the patient is having significant lesion. Okay. Routinely doing revascularization in asymptomatic, it is class 3, it is of no benefit. Okay. Yeah, but if the patient carotid revascularization may be done if the patient is having bilateral carotid arteries disease like 70 to 99% or 7 plus if the patient is having high risk of stroke. Okay. And carotid revascularization should be considered if the patient is having 70 to 99% with increased risk of stroke. Okay. So that is class 2B indication. Now, what is the time that you identify your patient is undergoing CABG, you identify the patient in carotid artery disease, what is the exact time you should intervene the patient for the carotid artery stenting or revascularization? So there are no random clinical trial that has compared the simultaneously carotid artery stenting, like simultaneously doing, or once you do a stenting and then you give the patient for the CABG. So there is no random control, but there are certain meta-analysis have been done and they have showed that okay, there is as such there is no major difference if you do simultaneous both at the time or you do first revascularization and then you give the patient for the CABG. Okay, so basically you can perform both the things. Thank you.